any importance, whether it is in India or overseas.
Absolutely.
So, and I don't know whether they have for various age groups, how they address the issues. I don't know when I'm talking to them whether they have even broached the subject with the parents about the importance of dental care and how it helps with all the other multiple issues that come with the facial muscles, etc., etc. So we're going to leave it to you to take over, and we hope that I think I have to change my name in mine, Brinda, because this is a new phone. Can you just change that name, please? I hate this Galaxy S21. And if everybody can please add their names, it'll make a lot of difference to a person who's actually addressing us, because when you ask questions, she will be able to address it directly. Yeah. Okay. So yes, I think we'll wait for another 5 minutes, if it's okay with you, Nidhi,
Yes,
because
perfectly.
we're looking at many countries that might be late in the evening and might have just come back home and Saturday. So
Yeah,
yeah,
understandable, ma'am. No worry.
yeah, we'll just wait. And I've also put it onto the Indian groups, because the population in India also, every time you reiterate on dental care, I think it makes so much difference for them, because there are notes to be taken. And like I would look at it as my age group and what happens in this particular age group, because every age group cannot be generalized. So I think you give it so well. So yes, we'll wait. Good afternoon, Mr. Galgamua. Can you unmute yourself, sir?
Yes. I'm Smith is also here. Yes.
Oh, very good, very good. How are you?
Fine.
Okay,
Yes. Okay. Yes. Thank you very much.
thank you,
Yeah.
thank you.
Good
So,
to
yeah.
wake up.
Hello.
Hello. Hi, Sumitra. How are you?
Yeah, I'm fine. How are you?
All well, all well.
He's a dentist.
Yeah, she's a dentist, and she's a renowned dentist in India. And Nidhi's knowledge on the subject is because she's done so much research, and we thought that we can start with dental care. And then, of course, there are so many other issues, but I need to catch hold of the right people. So I
Okay,
hope
okay.
more people join us, and you can listen to
Yes.
her, because as we
But
grow older, I think we
yeah,
ignore the dental care.
yeah. That is true.
Yes.
Yes, I have some queries about
Very
my
good,
doctor,
very good. Yeah,
about my
great,
doctor.
great,
And
great.
then
So I think there is somebody here, Brinda, who says Zoom user and Vivo 1804. Can we
I,
ask them?
yeah. Could we request all of you to please switch on your videos or at least rename yourself to your original names? Vivo 1804, I don't know who you are. And then there's a Zoom user. So if you could just rename yourselves, it will become easier. Another 2 minutes, Niti, and we can start. Anyway, we are online. So we are live streaming also. In case we'll then share the link.
Hello, my officer.
Hi. Hello.
Yes,
How are you?
fine.
Wonderful. Good to see you. Look at you smile.
Thank you.
Welcome.
Shall we? Brinda?
Yes, ma'am. I think we should start, ma'am.
Yeah, you'll start. Nidhi,
We're anyway
we
live
have-
streaming.
Exactly,
So
exactly.
we'll
And
share
and, and it'll come up on our YouTube also. So don't
Yes,
worry.
ma'am.
Okay. Yeah.
Yeah, it is
Thanks.
live stream.
Thanks,
Thank
Nidhi.
you.
Thank
Yeah,
you,
over
ma'am.
to you.
Thank you. I'm sharing the PPT, Brinda, now.
Yeah, thanks, Nidhi. Sure.
Let me know if it is visible.
Yes, it is.
Okay. So good afternoon, everyone, and thank you, Brinda, Rekhama, Asia Pacific Down Syndrome Federation for this wonderful opportunity. And I would like to say that when we started this Smile Special, our vision was in line with what Rekhama always believed in, dignity. And we asked one question from ourselves: what if dental care can start with the dignity and not with the diagnosis? So today, I would like to share how we have made dental treatment, try to make it accessible, anxiety free, and empowering for our community. It's not a charity, but it's the clinical best practices. So, when we talk about dental care, one thing which comes in our mind, all of us, teeth, smiling face, or the pinkish gums, the beautiful gums, right? But in our children and adults with Down syndrome, it is more than teeth. It is about their nutrition. It is about their sleep. It is about the intelligent sleep, speech, and the confidence. So we are treating the whole person health. And in the last 10 years, so this is a milestone for DSFI and the whole community because we are celebrating the 10th year of IADSC. That oral care is not restricted only to the mouth. It is as a whole person health. So let's begin by health is more important and it is more than teeth. So many people, they see us as dentists, but for our community, for children and adults with Down syndrome, we may serve as the first defense line for airway, nutrition, and even heart health. Eating and nutrition, when we address this issue, a narrow palate and a low tongue can make chewing really, really hard. We often, and I mean, it's universally reported by the parents that our children find it hard to chew. Therapists keep saying, make your child chew on fibrous food, on nutty food, on vegetables, on salads. But our children are really, really finding it very difficult. So the issue also lies in the mouth and which needs to be addressed proactively. This chewing issue or the uptake of nutrition from the first part of GI, gastrointestinal tract or gut. The first part is the mouth, right? Oral cavity. It impacts gut health. Obviously, it will impact the gut health because for gut health to be preserved, we need to take all kind of food and not only the readily fermentable soft food, because the more you chew, you are stimulating the production of saliva, and with saliva, you are producing more important gut friendly bacteria in your mouth. So this is one interconnection I all want you to understand, so that we take the oral health beyond the mouth, right? So when gut health is impacted, obviously the growth is impacted and the mealtime behavior is also impacted. So we are talking about lot many things, about the patterns our children adopt, even the behavior our children adopt, and how, with small interventions in a playway method, we can try to intervene in those and break those and redirect the brain for a better, healthier pattern, right? Now, speech and communication. So jaw development shapes the sounds we make, right? So many times you must have seen that our children are not able to make the lingo-palatal sound because the palate is so high. Till what length the tongue will go up and touch the palate? It is not touched. So there is somewhere either there's lip sync or the mixing of sound like l, r, these sounds, th, they are not very clear in our children's speech, right? The other thing is an open bite. You know, open bite when the front teeth, like our front teeth are meeting like this. They are not meeting. So there is a gap here, right? And either a cross bite. So this is the upper jaw, this is the maxilla, and the mandible. The lower jaw has to sit inside it. But in our children, it tends to reverse. When it tends to reverse, obviously the phonation, the chewing, and all the associated functions will be impacted. So these two things are really important. And the other thing which I would like to stress upon that whether a children or an adult, most of our time goes running after therapist, and out of that also the most important therapist is speech therapist, right? Even when they are adult, we always think, what if his speech or her speech would have been better, right? But one thing we can really, think about and bring in picture is the alignment of teeth. Sometimes everything is fine. Child knows how to speak. He knows how to pronounce. But this oral cavity, the articulators in this oral cavity may not be conducive or may not be in their favor. So go to the dentist. If you missed in childhood, maybe in teen. If you missed in teen, go in adulthood. So it's never late for our children. The third thing is sleep and heart health. In the last 5 years, lot of awareness has been created all around, not only in Down syndrome, but overall about sleep hygiene, sleep apnea, and snoring. And believe me, it's very common even in neurotypical. But now think when there are so many barriers, when there are so many hindrances, not only in the oral cavity, but also in the airway, don't you think our children will be more prone to sleep apnea? They are. 99% of the parents who have reported to our clinic have said, ma'am, my child is not able to sleep in one position at a stretch for 7 to 8 hours. Either they take the frog position or they sit and sleep or they keep changing their positions. I hope you will all agree with it. So when these issues, they are coming time and again, we just can't, brush them under the carpet. We need to address them. And if there is one reason which is in the mouth, we need to address it proactively so that the results are multi-pronged. Right now, I saw a child smiling. And when we talk about inclusion, we say our children are taking up jobs. Now they are in UNESCO. They are working with WHO even. Don't you think their self-esteem does matter? Their confidence does matter. Their external appearance and their smile does matter. So yes, dental hygiene, smile, good healthy smile does make or plays a very important role in inclusion and the total overall personality of a person. Am I clear till now? I hope it is not looking very theoretical because whatever I have taken from the 10 years of experience and association with Rekhama.
Honestly, you've broken it down so beautifully that I think the other organizations.
Rekhama, I think I'm not able to hear your voice. Is some problem with
Yeah, Mark, even I don't hear her.
Hello?
No. Yes, ma'am. Now you're audible again.
Yeah. So you're okay, Nidhi? I think all the parents, if you feel that you're able to understand what Nidhi is saying, put your thumbs up, please, and the questions will be taken at the end.
Yes.
Am I right, Nidhi?
Yes, definitely,
Yeah,
ma.
yeah.
Because
Because
it's
a
a
lot
big
of people, I think, are
presentation.
relating. They're relating beautifully to what you're saying,
Yes.
and I think all of us understand where you're coming from. But the
Yeah.
questions will come. Oh, lovely! All the thumbs are coming up. Great.
Thank
Look
you.
at the number
Thank
of
you.
lovely thumbs. Yeah.
Thank you. And one more thing. So all the pictures in my PPT are real, and please refrain from taking any screenshot of the children. Uh, so they are like my family, and please don't post it on any social media, the pictures. So, the common dental problems, we all are aware because we have been in this journey for so many years as parents or as advocates, as caregivers. We know they have cavities, tooth decay, right? They have gum problem, right? They have grinding of teeth. They keep their mouth open, mouth breathing, or they have dryness of mouth. They keep their tongue out, right? These are very common issues. We are going to address in a very simple way, and we will give you some assessment tools. So Ma said, when Brinda said this is for our whole Asia Pacific community, I said let's use this opportunity to make it very relatable and give parents, equip, empower them, give them some assessment tools so that they understand when is the time to take to the dentist, their self-advocate, right? So, if you have read this slide, I have kept it very simple. What one point I want to, bring on that these when you go to any dentist, they say they have delayed eruption. Teeth may not come at stipulated time period. It's okay. We say it's okay. These are not the roadblocks. These are the roadmap for us. They guide us. Okay, this is there. Okay, let me plan for future. How I am going to still better their oral health or still work for the future. So they don't limit us. They guide us. So I'll give an example, simple example. If your child is 1 year or 2 year and still all the teeth are not formed, please don't panic. It's in genetics. It's a genetic feature. It's universal. Accept it, but we have time. Now, delayed eruptions means what? That when you take your child to the dentist at around 1 year or 2 year, when all the teeth are not formed, this is the best time when the dentist can start the desensitization procedure in the dental chair and you can take it forward at home. So use it as an opportunity. We are using each and every roadblock which people say as a roadmap. When they say they have smaller teeth, that means if the gaps are there in between teeth, we have more accessibility in between the teeth surface and the tendency to get cavities is less. So, what general perception is that children or adults with Down syndrome get more cavity. Rather, it's reverse. They get less cavity and they get more gum problem. 99% of the children with Down syndrome will have gum problem, but the cavity risk will be lower. This is a genetic feature of this syndrome, right? When you say they have low muscle tone, okay, then this is an opportunity when you can use a simple ice cream stick to train my lips to close. And this can be done by a dentist. This can be done by you. Don't need to go to any therapist. When you start a partnership with the dentist, the small thing you can do. And a high palate. See, high palate act as a screen. This is my first screen which helps me to now make a whole roadmap how I'm going to screen your sleep. So it is not a challenge. It's an opportunity for us to work further. So yes, gum disease, they have very, very, very high risk for gum disease. And for that, I'm going to discuss very small and I think, yeah. So this is again one real picture of an adult. You will see missing teeth. You will see retained primary teeth are also there, and the permanent teeth have erupted. Missing teeth is there, and most important, what is there is the gum inflammation. All the gums are inflamed, and you can see multiple caries because the child has not yet developed a habit of brushing teeth twice. So all these dental problems, they affect chewing, swallowing, speech, and they are very, very, very important because nowadays we are talking about inclusion, and inclusion is also non-exclusion. So if we understand this, we understand that oral hygiene is really, really important. Now, this is how in the first picture, if you see, this is how the gums of our children look like. So this is a picture of an adult, but for children also, the small, small red patches, if they are visible, this is the first red flag. That somewhere the tooth, this canine is not properly positioned, the child is not able to clean. But you see, the gum inflammation is not restricted to one tooth, it is tendencies to spread, right? So what is the assessment tool? Lift the lip, lift the upper lip. So parents, this is the first assessment tool. Lift the upper lip. When you try, help your child brush teeth. Don't just brush like this or this. Lift it. Because of hypotonia, the upper lip tends to fall towards cavity, that is down. So we need to lift it up, right? And most of the inflammation I have seen in this area. So lift it and then brush. The second important thing is switch if you are using an age appropriate brush. Age appropriate means my child is 2-year old. I'm using a 2-year old. My child is 10-year old. I'm using a 10-year old. No, we don't want age appropriate. We want age appropriate communication with them, but not the brush because their mouth cavity is not growing as proportion to their chronological age. It's still small. So only the small oral hygiene aids, brushes will be accommodated in that. So second point which I want to emphasize on. There are some of the brushes I actually collected purposely to show to all of you. See, now if given a choice, I will choose this. This is the smallest. I can maneuver all around and I don't need lot of cooperation from your child because I'm not asking my child to adapt. I am adapting the tools for them. I'm not giving them unnecessary stress. I'm not fighting in the oral cavity or with them. I have modified it. It's so simple. Use this 2-year-old appropriate with some cartoon character or something like that, which is, quite enticing for them. Use it. And then see the change. You're able to move it all around, even till the last tooth. And this will keep the gum health also in place, right? The second thing is partner with your child. Don't make it a stress-free thing. Okay, what is the which? So there are 8 kind of intelligence in our children. The best is visual, right? We all understand they're visual learners. We at some point of time we make flashcard for them, and then they imbibe the thing which we want to convey very nicely. Do we all agree? Yeah, you can unmute and say they're visual learner. Which is their second strength? Which is their second strength? And everyone's obviously, but
Audio learner, audio
yeah,
visual.
but which audio? Rhythmic. Yeah. So you see, we made lot of rhythmic, and mother's voice is the best. I know nowadays social media has totally hijacked our lives. Uh, Rhythmic. So 1, 2, Put on your brush. 3, 4, take out the paste. 5, 6, let brush our teeth. 7, 8, wipe the face. When you keep doing it in a very rhythmic manner, they understand. And this, the short term and the long term memory, they really, really imbibe it like, like a sponge because they need it. Their brain is very, 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 they become supercharged when they see and when they go for rhythm. That is why they love to dance and hear, and because there is a rhythm in it. So we use these two energies, we use these two intelligence for their benefit. Count of 10. If you are tired, play some music in the background, humming sound, om sound, whatever. But bring it on day by day. Do it in a consistent manner. And don't change the prop at least for 21 days. To keep it at least there for 21 days. Then if you think that monotony is setting in, then you can change. So very small tips I'm giving you along with the assessment. What do you think we have missed here? One thing we have missed here. We have not talked about the nutrition part. Gum health is related, one, to the obviously the cleaning devices we are using, the basic brush I'm talking about right now. Second is dietary modification. What if I keep exposing the oral environment with lot of acidogenic bacteria or food, the food which is, readily fermentable, biscuit chips, Oreo biscuits, and candies. What is this doing? It's readily making that acid and helping in the production of bacteria, which is karyogenic, which makes cavities. We need to modify it. That means we need to give constant, frequent breaks to make the child get exposed to lot different textures of food, colored food, and taste of food. Fibrous food, my favorite is obviously salads and veggies. But yes, you can make in Maharashtra, South India, North India, lot of home cooked food, local food. You can use it. When you use it, you are actually activating so many things here in the brain. I'm not going deep into that. But those opportunities are very, very precious, not only for dental, but for speech therapy, for OT, for sensory desensitization and stuff like that. So don't ever think that you are brushing, but giving lots and lots of chocolates, candies, stuff like that, burgers, pizzas. You have to consciously take them out and replace them with healthy bowl of nuts, chana, whatever you think is local and healthy. And the child has an opportunity to chew on it. Because teeth are meant to chew food. If they are not going to chew food, they are going to chew other stuff. They are going to do teeth grinding. So, and they are going to do lot of this movement, because when this is deficient in getting opportunity, this has to work against gravity. Where it will work, it will keep working on, then they develop a pattern, right? The other thing we missed were the oral lesions. Yes, our people, they show oral lesions. Don't look into the whole slide. Only two ulcers are very important. One is aphthous ulcer, which may happen on the tongue, which may happen on the floor of the mouth, which may happen on the lip also, which goes on its own. It goes away on its own a day of 6 or 7. You just have to avoid spicy food, and you can just coat it with a layer of glycerine. That's it. It's self-limiting. It heals itself. And the other is mucocele. When our children bite on the lower lip, so this gets fluid filled, and it also get resolved itself. So these two oral lesions also we have to take care. And okay, our children may not report that they have ulcer. They may stop taking some food, they may stop taking juices. If they are like, very keen to take juices, they may stop. So maybe you have to examine once, are they getting any ulcers, or after use of antibiotics like amoxicillin, penicillin, or augmentin, it gives ulcer to our children because it alters the gut microbiome. And for that, you need to take some probiotic supplements or prebiotics, curd, chas, stuff like that, which supports the gut health. So that also we need not skip, though we tend to skip because they are not very frequently reported. Now we come to a very, very important issue, bruxism and delayed teeth. Delayed eruption, I already talked about. Delayed eruption it's a sign for us where we can really work on desensitization. It's not a failure. And the most important thing is once we see what is there in the mouth, we can plan. So we recommend a full mouth x-ray if some teeth are not in place by 5 to 7 years of age. So that is a window period. And if there are some impediments like there are barriers or there are some forces which are making the eruption process, uh, it is the teeth are not erupting, then we do some minor procedures to facilitate the eruption of teeth. Bruxism and teeth grinding is a very misunderstood concept because everyone for so many years were doing R&D only. We are still doing R&D. But now what we have come to, some kind of closure of the conclusion is that teeth grinding is not something our children want to do. If you see this in this picture, the lower teeth are already visible. It's being grinded half of the size. They don't want to do it. It is the body is telling something is something which need to work upon. If you start grinding your teeth, you will get tired after 2 minutes or 3 minutes. Don't you think our children also get tired? They also get tired. But it is not something in their hand. It is something which is happening, and it's a red flag for us that something as caregivers we have to work upon. So it might not be related to the position that we need to sit straight or keep our legs parallel to the ground or stuff like that. Yes, momentarily it does stop, but we can't make our children robot and make them sit still. It may not be totally because of stress. Yes, stress can trigger the already, so if their anatomy is compromised or if any function is compromised, yes, stress can aggravate it. But if it is only because of stress, it is not permanent. Bruxism should never ever become permanent. It tells that there is some problem. So nowadays, if a child comes with bruxism and child is in the teens, because now what happens in the teen, again, a growth spurt is coming. Growth spurt means now the body is growing, the demand is growing, but my breathing is not supporting my oxygen supply. So we take the history. Has the child bruxism or the grinding of teeth, has it increased of late? Is the child able to sleep? So there is one connection which again goes to sleep apnea. Is the child able to breathe through the nose and not through the mouth? If we eat through the mouth and not through the nose, we are supposed to breathe through the nose, not through the mouth. We have to be very, very, very clear with this. Because when we breathe through the nose, not only it filters, it humidifies the air, it has multiple roles, which is absent in the oral cavity. So this link, whether the child is able to sleep, whether the child has recurrent upper respiratory tract infection, is the child showing symptoms of adenoids and large adenoids and tonsils. So all these things are built into to come to a conclusion that what are the different factors which are aggravating this bruxism habit. One more thing, I have seen parents coming to clinic, 5-year-old, 7-year-old. Ma'am, the teeth shows gap. Do we need to close the gap? No. Every gap doesn't need closure. If the gaps are in between baby teeth, they're good. Why? Because when the permanent teeth will come, they will be double the size of the baby teeth and they have space already, right? So don't think that every gap needs to be closed. So mouth breathing, we have come again to the mouth breathing. So one thing we have to understand, okay, I'll bring that first. Sorry, I'm going a bit, yeah. So see, 2, 3 things we have to understand. Our children have narrow airway, passage, nasal. Very simple. In very simple terms, I'm going to tell. Then second, the oral cavity. Palate is almost V-shaped. So palate is actually supposed to house the tongue. Just close your mouth. Where is the tongue? It's going against the palate, roof of the palate, right? Of the maxilla, the upper. In a children, because palate is like this, the tongue is not able to, position itself. So where the tongue is going, it's out. Oral cavity. Third, if our children are very prone to adenoids and large adenoids and tonsils, further the tongue will come out because it will prevent the collapse of the airway. It has to maintain, so they are not able to breathe through the nose because already in obstruction they try to breathe through the mouth, right? So, and obviously the other things, they again increase the chances of sleep apnea, like obviously obesity, sedentary lifestyles, and stuff like that. So if you say this is the typical from the profile, the closed, the open mouth position. Now, you know what happens when this mouth is kept open? So it creates a vicious cycle. The tongue is low because the child has to breathe, and the lower lip has to work against the gravity. When the tongue is low, again the palate keeps collapsing, keeps collapsing. So it's the position of the tongue against the palate which helps it to expand like this. When this is expanded, this is also getting more space. This is also growing. When this is collapsing, because nobody is there, nobody is there to prevent this force, and this has to be prevented by the tongue. It keeps collapsing, it keeps collapsing, tongue keeps coming out. So it's like a vicious cycle. So we have to understand this, that it is not only the dental, or it is not only the ENT, or it is not only the sleep. The whole community of professionals, they come together, diagnosis, understanding the root cause. Where is the obstruction in the mouth, in the airway, here? Analyzing it, and then working as a team and bringing in the change, right? So this, I took it because I was in continuation, so I thought I'll take this slide first. Okay, we are going to now, yeah. So one more point, which I was reading some articles and I read in it, that if you try just this thing and you are not addressing the underlying adenoids and the tonsil issue, this is just like putting a tape actually on the problem. So everything has to go hand in hand. That is why Rekhama always says that ENT evaluation is so important. It is actually very important that our children, if everything is fine here, obviously we can't do much about this right now, but about adenoids and tonsils, we can look into the mouth, and even as parents, we can look into the mouth and see whether the tonsils are enlarged or not. So everything has to work as a coordinated team and not in silos. So how do we overcome anxiety, dental anxiety? See, when we talk about our children, we have two palettes, one as parents and one as a professional. So we both have to coordinate to make this journey smooth and, very successful. So it is not that the dental visit should start at the dentist office. The preparation should start from the home. How you make your child prepare for the dental visit. I always tell that don't make the dentist villain of the story. Your dentist will put this or dentist will give injection. No. There's so many beautiful social stories we tell our parents to make. Take pictures of the dental clinic or, and show it, and then when the child is familiar with the setting, then you bring the child to the dentist. And dentist doesn't take the child to the chair in the first go. There's so many techniques we practice. We tell the child in a very play way method, what are these things, what I'm going to use, in a very non-threatening way. And the other thing is nowadays we are also working with a lot of dental organizations to make the dental clinic sensory friendly so that it's calming on their nerves, it is not overwhelming, right? And obviously if uh, things permit, you can definitely have a 2-minute video call with your dentist even before you schedule the appointment. So what goes in a long term when we say create a dental home? Dental home is not like one-time visits. It's like a lifelong partnership with the dentist where they are not only helping you prevent the cavities, but when they need actual treatment, how they do it in a non-threatening and a sensory friendly child-oriented center or child-oriented environment. And for this, parents' partnership is really, really, really important. If even one leg of the triangle is missing, then we are not able to, sustain it. Now, one more thing I want to show. So we all talk about dental floss. We say dental floss is important and we should was my video off? I didn't know that.
No, it was only for a few seconds your audio went off. Now you're okay.
Okay. So, can anyone, all of you can see the floss, or shall I stop share, or I'll show it later, Brinda?
Show it later, Nidhi. Show it later.
Okay.
दिख नहीं रहा है. It
ठीक.
won't be clear. Yeah.
So, I have made one adaptive toothbrush also. I'll show you. So, for the grips, we can definitely modify it with a lot of things. Now, a lot of things are available on Amazon and other e-commerce platforms. And floss, yes, dental floss is really, really important. Initially, we used to say, okay, just brushing, that is the basic you do. We now say, no, dental floss is also important. And if possible, we take our child to that level. Visual cards, as I already mentioned, very simple. So we have a visual memory of 5 pictures in a flash of 5 seconds. So maybe you can start with 4 and that they will help as a great tool. And if you're working in tandem with any OT, they will definitely suggest you YouTubes, the plain one, the textured one, right? I just want to show you one video, it's a very fast video, how we modified this child behavior in the dental chair. So what was the story? He's 10 years old. His name is Harsh. Mother said, ma'am, he brushes. So he had rampant cavities. So every tooth had a cavity. But he brushes very fast. So, okay, we said we'll put a sand timer. Let him see. And mother said one more thing, ma'am, he is scared of heights. So, okay, let's incorporate that also. So after third sitting, we became very good friends and we used to talk about his favorite cartoon and he used to talk about, ma'am, what next? I mean, we had a very good conversation during the treatment time. So in the fourth sitting, mother got his brush and said, "Hush, come and let's step on a stool. I want to see your full face, how you brush." And so giving him some motivation, he climbed on the stool, and mother was so happy that now, I don't know how he is climbing. He is scared of heights. And then he showed me how he brushes, and with just little bit of physical prompt, I told him how to brush his teeth. So just doing, helping him with verbal and physical prompt. That's it, in a very friendly way. And this is just a slide I had put, that from 2016 to 2026 with DSFI, we are able to transform the whole, gamut of dentists, professionals, even in schools. So many workshops have been done, and DSFI guidelines, their targeted resources, the self-advocates, they have made dental care more inclusive and supportive. So, big round of applause for everyone in DSFI and Rekhama. So, some more tools which I would like to give, if there are some professionals, we have to welcome our individuals by name. We have to create those small resources, those adaptive tools, so that every family feel empowered, and the advocacy should go on. They have to be guided, and we have to amplify their forces. So I think this also we have covered. This also we have covered. This also we have covered. Sleep apnea, it affects heart, and it affects overall quality of life. The sad part is that studies are very less about the effect of sleep apnea on overall life quality or heart health in our country, but we are working on it, and hopefully we'll come up with some studies. But in general population, a lot of studies are being done, effect of sleep apnea on the heart health. So this is something we have to really work upon, because mouth breathing changes tongue position, tongue posture, muscle function, palate development, airway health, and it not only redirects the nervous system, it creates panic. And we want to bring that awareness and education, that we have to work hand hold the other professionals, make it a team, and work for the betterment of our community. Because when we support the nasal breathing and proper muscle function, we are not just shaping growth, we are supporting proper sleep regulation and thriving. So some of the tools available in our clinic for the analysis, some of the patients who have undergone palatal expansion, obviously after ruling out any adenoids or tonsils. And these are some studies which we have taken the data from, that it does maxillary expansion, the expansion of the upper palate, which we do. It increases the nasal volume and upper airway volume. It help reduce the upper airway collapse during sleep. And it is very relevant in our children. So now there are some stages. Most of us may be confused, ma'am, my child is this year old. So do you think, yes, at age 1, we do look for tongue tied. We do look for reflexes. We do look for mouth breathing and feeding difficulties. That is also a time when you go to the dentist. At age 7, as I said, if teeth are not erupting or erupting in a very mal way fashion, or you think there are incidences of bedwetting, you need to see a dentist. Then at age 20 and 40, 25 and 40, obviously, if you think there are episodes of anxiety, fatigue, OSA, and high BP, unexplained high BP, yes, you can see a dentist. And age 65, if severe health complication like diabetes, stroke, Alzheimer, cancer. So many bacteria in the mouth affect actually how our brain function, Alzheimer behaves. Will the diabetes be kept under control or it will escalate? So there are so many things. I think I'm already exceeded, so I'm not going to play this. So if you go, there are some so I try to summarize it according to this session, but there's so many things to be learned and so many which are relatable because they're lived experiences of uh, our children and adults. From simple checkup to simple non-drill fillings to full mouth jaw expansion, modification of attitudes, adoption. So you can Google us maybe. We are with DSFI also on their channels on the YouTube, and you can scan this to know more about what we are doing or upcoming programs or stuff like that.
Thank you, Nidhi. Oh my God,
And
that
the
was.
last, that's
Can
the
you hear
last.
me?
The
Can you hear me?
advocacy should continue. It should not stop.
Yeah, can you hear? Can you hear me?
Yes.
Yes, ma'am, you're
Okay.
audible.
So Nidhi, I'm just thinking that this has given us such an amazing perspective of one area which is called dental care, but you have covered everything else. Like I feel that areas like sleep and speech and breathing and eating and diet, you have covered everything. But I have one question, Nidhi.
Yeah.
Is there a lot to do with sensory in this? Because even for us, when we go to a dentist, the first thing we say, "Oh my God, it's going to give us that sensory, feeling that it's going to gnaw at my jaw." And so I just want to know that, do the children, like especially when it comes to bruxism, is it to do with sensory, or is it habitual, or is it something that we can alter?
Okay, so Ma, I'll give you, I'll start why bruxism starts in a neurotypical child.
Mm-hmm.
And in mixed dentition is when you have primary teeth, baby teeth, and the permanent teeth are also erupting. Jaw is growing, right? And see, the upper teeth have to meet lower teeth in a particular fashion. If they are not meeting, they are trying to find a stop where they can meet because this muscle has to rest, right? If this muscle will not rest, it will tend to brux. Teeth will brux, right? So when this mixed dentition is there, there's something changes in the mouth and the muscle they start, they start going into spasm and which leads to the grinding of teeth. In our children, bruxism starts in the similar way, in a normal way, ma, because growth is same, na. In our children also they have mixed dentition, they will also
Yeah.
show double teeth, right? But because now something else is going on, they are having those episodes or recurrent episodes of upper respiratory tract infection. They have episodes of sleep apnea. Stress is also coming. Ma, you see, from the time 14 years now with Ashi, the next month is her birthday. She's 15. Every parent has to go to therapy so many times. I mean, I was just finding out. Average, we go to therapist 5 days in a week. Don't you think that stress is also building up in a child's mind?
Totally,
And the
totally.
parents' expectation, ma, parents' expectation. Even if I see myself as a parent 13 years down the line, I think I was a super anxious parent.
Yeah.
And I transferred that stress to Ashi. I openly admitted, Ma knows my journey very well. Everything added on, they have emotions. They have, we think they are not expressing. They may not be expressing the way you want, but they're expressing. Bruxism is also a way to express, but also a red flag to say that there's something which is happening. I've seen, Ma, there are so many children with whom we are giving so many sensory input, but still the bruxism has not gone, which has led us to take that intervention. I'm
Okay.
saying there is a sequence where we take the intervention, the non-invasive first and then invasive. But there are times when non-invasive doesn't work, then we have to
Doesn't
go
work.
to the invasive one.
Okay, so I think we'll open the thing for questioning, and anybody
There's
who has any questions,
I'll
please
just
open
show
up.
this once, then we can start because
Yeah,
I
yeah,
purposely brought all these.
yeah. Right, right. Amazing coverage. Amazing. You've
Then,
really covered everything.
thank you.
Yeah,
So
go
when
ahead.
we talk about the dental floss, one again tip I would like to give, don't
Mm.
start with this because wrapping it around the fingers and then manipulating it around every gum area will be difficult for them. You can start with this handheld, right? Suppose these are my two teeth. You have to just tell your child to put it like this. Though there is a proper technique, but obviously from online mode, I can't teach you. So, and start only with the interior, the front teeth, because they can see in the mirror and do it. So, and rest you can obviously, once they are desensitized for this, say this will also need desensitization, then you can go to the dentist and learn the proper technique so that you don't land up with harming the gums. So this I got for all of you to show. Don't buy this for your child. You can buy this for your child. And if you have learned flossing technique, then you can teach. Otherwise, I'll recommend go to the dentist. This is better. This I modified. This is with the air dry clay. So many people ask, ma'am, where will I get the modified? It is so costly. It is so difficult. With the air dried clay only, I did it. With your child, what you can do. So they are even, stuff available at the dentist place. And what we do is we take the impression of the child's fingers like this, and then we set it. So it becomes permanent, and then they can put it around any brush and use it. So these tools are available, and go for a very soft and small head brush like this. I got for my, this is a 2-year-old brush. I give it for my 5-year-old brush because he gets very this thing that I don't want to brush. I said, okay, I'll give you a very small brush and with some trendy cartoon characters, stuff like that. So you can make it very, interesting for your children. Do it. I mean, keep experimenting for something new. Don't invest too much. I don't want you to invest too much, but in simple, small, and make it play. Yeah. Now we can take the question.
Nidhi, there's a question in the chat box. There's only one from Surekha. She wants to know if you could help her with a dentist in Hyderabad
Okay.
for her 14-year-old.
I'll ask in my group and connect you to someone in Hyderabad. Okay, I will.
Yeah.
Yeah.
If there's anybody else who wants to ask questions, I think you could go ahead, please. Anybody has any questions for Dr. Nidhi?
I think generally, Nidhi, you have done it such an amazing presentation that I don't think we have any questions. I'm only wanting one question.
Yeah.
Yeah,
How helpful is it for the jaw expansion for breathing?
Okay, so my jaw expansion has been done for the last 100 years. 100 years से हम कर रहे हैं, and I think we have done more than 500 patients in our clinic. Then we thought of bringing it to our children. And very unfortunately, as I mentioned, there's very less literature in India how jaw expansion supports breathing. But if you see, Ma, there are so many articles from even the Sleep Medicine Society from Brazil or from Colombia, and they support and they say that maxillary expansion really, really helps. Why in children with Down syndrome, the compliance for CPAP and BiPAP is very less, and it is like dependency on an external device where you can change the anatomy permanently. And when you change the anatomy permanently, you don't need to depend on anything. We did for Ashi when she was 8-year-old, and she is sleeping nicely. She's 15 now. So at 8 years of age, we did for her, and things are pretty well. Now we are doing her Invisalign for the alignment of teeth. One tooth which is troubling her. That's it. So things become very easy later on because when we are changing the anatomy, we are giving them more chance to breathe through their own body, through their own nose. And I think this is what we want our children to be self-reliant and not dependent on anything. So I think it's a go. It's a yes for our children.
Yeah,
So
great.
it is not
So-
only the breathing, it's also the sleep, the speech. It's all the eating issues, how the motor and the pestle. So motor and the pestle, the way we do now, grinding in for our chutneys and all. So it's all
Yeah.
for our teeth. If they work or they sit nicely, upper teeth in the lower, then the chewing force is excellent. They chew, and when they chew, they don't indulge in those soft junk food. When they will not indulge in soft junk food, they will get the feeling that they are getting, full. These sensory receptors in the gut will be activated. When these will be activated, the tendency to overeat will be less. So, it's a whole
It's, yeah,
cycle.
agreed. It's a vicious cycle and it really doesn't stop at one. It just,
Yeah.
everything is connected. Yeah. I think somebody,
Yeah, anybody has a
but-
question?
yeah.
Mr. Gargamova.
Yeah, Dr. Nidhi, this is the problem with my child. Her upper and lower jaw doesn't align. Yeah, uttering, open here, see. The lower jaw is a little in front of than the upper. And sure, can
I
you
can
see?
see it, ma'am, from here I can see. I showed it
Yeah,
in
yeah, yeah,
that.
yeah. Yeah.
Ours is like this, but our children, they reverse. So what happens is when the upper jaw is not, so it's actually the upper jaw which guides the development of lower jaw growth. But in us,
Uh-huh.
what happens because the palate keeps growing up, and the lower jaw has to grow. So what it happens, it locks the development of the upper jaw. So it becomes
Uh-huh.
cross. It is cross bite.
Mhm.
So if she is a child, we do rapid maxillary expansion, we do fixed and we have removable. If she is an adult, then we have to do some invasive. So now the technology is way advanced than it was 5 years back. So it's a whole revolution of technology now. And we do it 3D printing with AI tool, and it is very much possible. Though, the trajectory of treatment will be different, but treatment is available.
Treatment available. What should we do? You sort of cut it and push back or something like that?
No,
Something like that?
cutting, no
No,
cutting.
no,
We
no, no,
don't.
no.
We are not cutting it. So for assessment, you need to go to a orthodontist, a airway orthodontist. They have lot of tools, right? In-house tools, or they will send you to an X-ray center where they
Uh-huh.
assess how much, if growth is left, or how much with their appliance they can expand. So they have the whole system in place. We don't randomly, in the air or go blindly. The whole system is in place. So you need to see a very good orthodontist and they will guide you from A to Z.
Okay. Thank you very much. Thank you very much, Dr. Nidhi.
Yeah. Thank you so much, Nidhi. I think we have done and we have taken so much of your afternoon time. And we send you back to your family, but God bless you. And thank you so much for giving us such a beautiful insight. And I'm feeling so good about it because I think a lot of people in India itself needed an opening into this. But again, every time you talk, it's new. It's again new, and we keep learning. Thank you so much. God bless you. God bless you.
Nidhi,
Yeah.
I'll be
Thank you.
sharing the link, the YouTube link now with everyone. And if they want to connect with you, should I share your email ID or how would you like them to connect with
You
you?
have my email ID.
Yeah, I have your email ID.
Yeah.
I'm just asking, should I share that
Yeah,
if they
you
ask?
can. Otherwise, you can share Smile Special number. I have sent you.
Okay.
Yeah.
Yeah,
Great.
thank you, Nidhi.
Thank you. Thank you. God bless you,
Thank you,
Nidhi.
Nidhi.
God bless you.
Bye, everyone. See you all
Bye.
later.
Bye.